Alright, hi guys. I hope all of you guys have appeared for computer-based offline test, and we are here to discuss some of the questions that was asked. Most of the questions were on the easier side. Some questions were a little tricky or on the newer side. Let's see what are the areas that you could have avoided while solving an MCQ, while marking the answer of an MCQ. So as I told you in previous discussion as well, that we are going to quickly understand what is the answer and reason behind the answer, because the detailed discussion has already been given in printed form to all of you guys. In pharmacology, we had a very first question about antibiotic medication is given to volunteer in phase 1 clinical trial in several doses over a week in order to find the ideal dosage that minimizes the toxicity while keeping the blood concentration above the minimal inhibitory concentration. Okay, so you are keeping the plasma concentration above MIC. Okay, so for example, this is the minimal inhibitory concentration, and you are trying to keep the plasma concentration above MIC. Researchers discovered that there appears to be variation in the medication half-life among the subject. So different subject is having different half-life. Which of the following parameter, if increased, you are trying to bring a drug in the market, it's in the phase 1, okay? Which of the following parameters, if increased, further extend the drug's half-life? Okay, so this was again a very easy PG question. Even if you do not want to read the above 4 or 5 line, doesn't matter, just read about this one last line and your answer is already going to be there, that which of the following parameter, if increased, further increases the half-life. Now always remember guys, that I used to tell you that half-life, what is the definition of half-life? That is time required to bring the plasma concentration to half of the previous plasma concentration. T half-life that we have, इसका formula क्या होता है? 0.693, the constant value, and it is directly proportional to volume of distribution. Higher the volume distribution, higher will be the half-life, and inversely proportional to clearance. You see, if the volume distribution is high, that means the drug is mainly in the tissues or mainly in some other body compartment. So slowly and slowly from that body compartment the drug will be metabolized and they will be coming to the circulation, and ultimately the T half-life is going to increase. So if the volume distribution is high, T half-life is going to high. So if you know this formula, you can easily have the answer of this one, that which parameter if increase, the T half-life will increase, that is going to be volume of distribution. Now let's read and rule out other option as well. Oral bioavailability. What is bioavailability, guys? Amount of drug reaching the systemic circulation after the first pass metabolism, that is bioavailability. If you are going to see, if you are going to give a drug, let's say orally, the drug will be coming to the systemic circulation, and before it comes to the systemic circulation, it will passes through the first pass hepatic metabolism in the liver. Now if a drug is given orally, they will via portal circulation, this is the portal vein, via portal circulation the drug will reach to the liver, and after reaching to the liver they will undergo first pass metabolism, and amount of drug that is reaching the systemic circulation after first pass hepatic metabolism is bioavailability. This is the basic concept. Now let's read option B, oral bioavailability. If the bioavailability will increase, will it affect the half-life? The answer is no. Bioavailability if increase, if there is increase in the bioavailability, or if there is a decrease in the first pass metabolism, they can actually increase the plasma concentration. They can increase the plasma concentration. कितना ऊपर जा रहा है, minimum inhibitory concentration की कितना ऊपर जा रहा है, that it can decide. It can go further up, but it will not be deciding the half-life. Remember that. GFR, glomerular filtration rate, higher the GFR, that means the drug is going to be excreted mainly. Peak serum drug level will be deciding the plasma concentration. It is not going to decide the T half-life. It can decide the Cmax, but it will never be deciding the half-life of the drug. Half-life is going to be decided by directly proportional to volume distribution and inversely proportional to the clearance. I hope it is making sense to all of you guys. Let's see the next one. A new antiviral drug has been developed for the treatment of HIV infection. During the initial testing, it had a high rate of treatment failure, okay, due to continued viral proliferation in the brain. But when an adjuvant drug was combined, okay, so there is a drug X, when it is given alone, it is having high treatment failure. But what they are telling, but when an adjuvant drug was combined, the success rate of the drug improved. So that's good, है ना? So they are saying that drug X is having less response, है ना? There is going to be treatment failure. ठीक है? Next, that is saying along with drug X, they are adding the new compound, है ना? The new compound Now they are telling the treatment is getting good response, and we are having good response, the desired response, right? I think that's समझ में आ रहा है. Now let's read the question further. The biochemical study showed that the addition of adjuvant drug did not change the serum concentration of the antiviral drug. Okay, so for example, if you're going to see drug X alone and the plasma concentration is going to be, let us say the plasma concentration, example I'm telling you, let's say the plasma concentration is 1 is just a number, or let's say plasma concentration is 100, then the plasma concentration is 100 in both the scenario. 100 I'm just taking as an assumption. You can take 1 2 3 5. That means plasma concentration is unchanged. कहने का मतलब ये plasma concentration is unchanged even after adding the newer compound. Okay, the biochemical study showed that the addition of adjuvant drug did not change the serum concentration of the antiviral but drastically reduced the viral load. है ना, तो वायरल लोड तो कम हो रहा है in cerebrospinal fluid at 1 month of the treatment, and copies were negligible in the CSF after 6 months. Okay, so look at the question, very beautifully framed question, that when it is given alone there is treatment failure, although the plasma concentration is going to be same in both the scenario, है ना, but after 6 months when they have added, after 6 months the new drug added after 6 months, the viral load is negligible, है ना, viral load is markedly reduced. That means ये जो drug alone हम दे रहे थे तो कुछ तो ऐसा हो रहा था कि drug alone काम नहीं कर रहा था. Although when we have added the new drug is not increasing any plasma concentration of the drug. Try to understand, they are not actually increasing the antiviral load का, है ना, load, antiviral drug का load नहीं बढ़ा रहे थे. By which mechanism is the adjuvant drug is able to improve the viral control? So you see, usually what we see, whenever we give one drug alone and it's not responding, we add a new drug, and when we add the new drug, the overall plasma concentration of the antiviral drug will increase, but here we are not, they have not increased. So that means the new drug has simply boosted the effect of the other one, so it is having boosting effect or blocking the first pass metabolism. You see, what is first pass metabolism? The one that is happening in the liver, the one that I showed you here, the one that is happening in the liver is first pass metabolism. If the first pass metabolism is blocked, or if the first pass metabolism is inhibited, the plasma concentration will be low. Plasma concentration will never be same. If the first pass metabolism is inhibited, first pass metabolism is blocked. First pass metabolism is blocked. That means plasma concentration will be more. है ना, फर्स्ट पास मेटाबॉलिज्म नहीं हो रहा है तो मोर एंड मोर ड्रग विल बी रीचिंग द सिस्टमिक सर्कुलेशन, है ना, प्लाज्मा कंसंट्रेशन विल बिकम मोर. Inhibiting cellular efflux transporter. Okay, so there is a drug, this is the cell that we have, let us say, and whenever we are going to give the drug alone, sometime on the cell membrane here we are having some efflux, है ना, जैसे for example P glycoprotein, they are the efflux pump. So sometime when we give this drug alone, they might pump it out immediately, they will throw it out immediately, they will not allow the drug to stay here. I mean intracellular load बढ़ने नहीं देगा, concentration बढ़ने नहीं देगा, they will stay outside, है ना, they will not go inside the cell. Okay, so inhibiting cellular efflux can be possibility. Let's see other option. Decreasing cytochrome P450 metabolism. What is cytochrome P450? It is the microsomal enzyme that is present in the liver. Cytochrome P450 metabolism अगर decrease हो जाए, if you inhibit the microsomal cytochrome P450 metabolism, that means the drug inactivation will be low, and this condition will also increase the plasma concentration. If the metabolism of the drug will be slowed down, अगर new drug क्या किया, metabolism को कम कर दिया, that means the drug, new drug का देने की वजह से प्लाज्मा कंसंट्रेशन तो बढ़ जाना चाहिए, बिकॉज मेटाबॉलिज्म को वो इनहिबिट करता, तो इट इज नॉट डिक्रीजिंग मेटाबॉलिज्म, इट इज नॉट डिक्रीजिंग मेटाबॉलिज्म. Diminishing blood flow to the choroid plexus. If they will diminish the blood flow to the choroid plexus, how will they reduce the viral load in the CSF? So this is a very dummy choice. Inhibiting the efflux pump, this could be the possible answer. Let's understand why and how. Because they are saying if they are going to give the drug alone, it is not responding. Maybe P glycoprotein is active and they are trying to pump out, they are trying to pump every drug that is given inside. So what they have given, they have given a drug in addition to this one, है ना. तो इसके साथ इन्होंने एक ड्रग ऐड कर दिया जिसको मैं रेड से शो कर रहा हूँ. सो इफ दिस रेड ड्रग इज एडेड अलोंग विद दिस वन, तो प्लाज्मा कंसंट्रेशन ऑफ द ड्रग विल रिमेन सेम, बिकॉज जो भी ड्रग था प्लाज्मा कंसंट्रेशन उसका चेंज नहीं हो रहा है. नाउ दिस रेड वन दैट इज द efflux pump or P glycoprotein pump inhibitor, they will go and they will inhibit this one, and now the drug can get accumulated inside the cell, and this drug that is getting accumulated inside the cell will actually be having antiviral response. Now it can have antiviral response. I hope it is making sense to all of you guys. So the way it is possibly working is inhibiting the cellular efflux transporter. Again, this is just a common sense wala question. 35-year-old woman who experienced bouts of severe nausea and vomiting on a recent cruise vacation has come to OPD because she is fearful that it might happen again in her upcoming trip. She is feeling fine now, not taking any medication, no significant medical and surgical history. Her physical examination is also normal. Everything is fine. पहले इनको एक मान लीजिए गए थे, motion sickness हुआ होगा, sea sickness हुआ होगा. So for that she consumed some drug and ठीक हो गया, है ना? And she is afraid that it might happen again. So what medication should she be prescribed and side effect that she need counseling for? Okay, so अगर मान लीजिए ये motion sickness है, if it is going to be a case of motion sickness, I always say the drug of choice is going to be hyoscine, which is also given the name as scopolamine. It is the drug of choice. And motion sickness के लिए ये drug of choice अगर होगा तो इसका important side effect because it's the anticholinergic drug can lead to blurring of vision. It can lead to urine retention, blurring of vision, urine retention. It can also lead to, in addition to blurring of vision, urine retention, it can also lead to dryness of mouth. In fact, all the anticholinergic side effect will be seen. All the anticholinergic side effect will be seen. So we are having scopolamine that is associated with cough, no. And they have given third ka diya hai 2. Third ka 2 is dry mouth, yes. So they can cause dryness of mouth as well. Now let's read other option. Metoclopramide. What about metoclopramide, guys? Metoclopramide is one of the D2 blocker. And ये क्वेश्चन बार बार आ चुका है आपके NEET-PG, INI-CET, FMGE. Metoclopramide is a D2 blocker. And this metoclopramide being a D2 blocker, they actually crosses the blood-brain barrier and they are going to be associated with your extrapyramidal symptom, जिसको कई बार word extrapyramidal symptom ना देखे abnormal posture examiner used to give. And the management of this one, we are going to use centrally acting anticholinergic drug by the name of benzaxole, benztropine. These are the agents that can be utilized. Remember, okay? Metoclopramide 1 का दिया है for diarrhea. No, diarrhea is not something that she needs counseling for, है ना? They are the D2 blocker actually. ठीक है? Prochlorperazine, that is again antipsychotic drug, can be associated with your problems like extrapyramidal symptom. 2 का दिया है 3. There is frequent urination. No, there is no such effect like frequent urination. And ondansetron, it's the drug of choice for nausea and vomiting. And 4 ka diya 1 cough, they will not be associated with the cough. So correct answer for this one is going to be option C, that she, you need to give her this drug, and you can even counsel her that in upcoming trip you might experience dryness of mouth, or these are the important side effects when you take scopolamine. Which of the following statement is incorrect about pregnancy in epileptic patient? Pregnancy in epileptic. What is the drug of choice for epilepsy in pregnancy? Drug of choice for epilepsy in pregnancy is going to be your levetiracetam. Levetiracetam. Or other drug that we can utilize will be brivaracetam. They are actually SV2A inhibitor. Levetiracetam, brivaracetam, they are actually what? They are SV2A inhibitor. Levi-SV. क्या बोलता मैं? Levi-SV है ना? SV sound Levi-SV sounds like BV है ना? SV, BV, Levi है ना? So pregnancy में is the drug of choice, and remember they are anti-epileptic drug. So we are always supposed to add the supplement of folic acid with them. Folic acid का supplementation will always be added with them. And apart from that, other alternative drug that we are having earlier, we also consider this as a safe. This is also safe. See, no drug is 100% safe in pregnancy. They all have some or the other risk of epilepsy, but if you are going to see drugs like valproate that is causing spina bifida compared to levetiracetam, that is having much lesser risk. So which of the following is incorrect? No anti-epileptic drug is safe in pregnancy. Yes, no anti-epileptic drug is 100% safe. पूरी तरह से कोई नहीं है. Folate supplementation is must, yes, to decrease the neural tube defect wala risk. Immediately stop anti-epileptic once pregnancy is detected. No, never ever stop anti-epileptic drug, है ना? So let us say anti-epileptic agent has to be continued at stabilized doses. Yes. So let's say if there is a patient on AED मतलब anti-epileptic drug, patient on AED मतलब anti-epileptic drug, and she actually conceived and presenting with the urine pregnancy test positive. Conceive कर लिया, UPT positive आ गया. So what is the advice that you are going to give to this patient? What is the advice that you are going to give to this patient? Continue the same. Never stop the drug, because stopping the drug can be more problematic compared to the epilepsy itself. Continue the same and keep monitoring the pregnancy. आप pregnancy के growth को monitor करते रहिए. However, a patient on anti-epileptic drug, and she is coming to you seeking advice. She is coming to you seeking advice to conceive. Doctor, I am on this anti-epileptic drug and I'm afraid that this drug might create some teratogenic effect to my baby, upcoming baby. I want to, conceive. Please give me some advice. So what is the advice that you are going to give to this one? That you are supposed to slowly shift to safer anti-epileptic drug. Safer anti-epileptic, AED मतलब anti-epileptic, जो ड्रग ले रहे थे उसको टेपर करके बंद कर दीजिए और दूसरे को इंट्रोड्यूस करिए. शिफ्ट टू सेफर एंटी एपिलेप्टिक. यू आर सपोज टू स्टार्ट फोलेट और फोलिक एसिड टू दिस पेशेंट एंड स्टार्ट द कंसीविंग प्रोसेस. एटलीस्ट 3 महीने के लिए इसको देंगे. स्टार्ट द कंसीविंग आफ्टर 3 मंथ, मतलब 3 मंथ ऑफ फोलिक एसिड का डोज, 3 month of folic acid का supplementation. And what about folic acid after that? It should continue 3 month का folic acid supplementation, and after this one एक बार conceive कर लिया, so she will continue the folic acid once again. She will continue the folic acid once again. The folic acid will be continued throughout. ठीक है. So 2 तरह के पेशेंट आएंगे, एक conceive कर चुकी है और एक conceive करने के लिए आ रही है ना. Safer will be levetiracetam. Given that never stop anti-epileptic drug. Remember, given that dapsone is used to treat fungal infection, leprosy, and immunomodulator, what is the mechanism of action? This was a very simple question. They could have simply asked what is the mechanism of action of dapsone. Dapsone हो गया है ना. They are all folic acid synthesis inhibitor. Folic acid synthesis inhibitor by inhibiting the folic acid synthase enzyme. So they inhibit the folic acid synthase, and remember they are the dapsone as a drug. They are the drug of choice in a patient with leprosy. They are also the drug of choice in a patient with dermatitis herpetiformis. Dermatitis herpetiformis. They are also utilized in certain fungal infection, or I would say in some ENT में भी आपको पढ़ने के लिए मिलता है some condition जहाँ पे भी हम dapsone use कर सकते हैं ना. जैसे in a condition where there is chrysomia larva जहाँ मिलता है ना. कई बार there is in the nasal area you might find है ना, there will be larva of chrysomia, वहाँ पे भी हम इनको utilize कर सकते हैं है ना. Which of the following criteria used to identify the drug that require caution in geriatric patients? So caution in geriatric patients mainly will be seen with drugs like antihistaminics, because antihistaminic will be causing sedation. Drugs like anticholinergics, because these are the drugs, sedatives. These are the drugs that will be more problematic because they can cause constipation, they can cause drowsiness, blurring of vision, and that will be more problematic. So geriatric patient के लिए beer criteria, geri के लिए beer criteria, geriatric के लिए beer criteria will be utilized. Apart from that, ransom criteria कहाँ use करते हैं? We use it in acute pancreatitis है ना. Acute pancreatitis को grade करने के लिए L ascorial for ALS का diagnosis, L नाम में ही हो गया, L ascorial ALS, LS diagnosis. McDonald मल्टीपल स्क्लेरोसिस. तो मैकडोनल्ड में मल्टीपल फूड आपको मिलते हैं, मल्टीपल काइंड ऑफ बर्गर आपको मिल जाते हैं, ऐसे याद कर लो. मैकडोनल्ड मल्टीपल स्क्लेरोसिस. LALS के लिए, रैंसन एक्यूट पैंक्रेटाइटिस, बियर जेरियाट्रिक के लिए. A patient with cancer is undergoing chemotherapy. On blood examination, the platelet count were reduced after the previous cycle of chemotherapy. Okay, so there is a case of thrombocytopenia, and to treat the thrombocytopenia, what are you going to use? So oprelvecin, they are the interleukin 11 agonist. Oprelvecin is one of the interleukin 11 agonist. They are the interleukin 11 agonist, oprelvecin. ठीक है. Other alternative agent that we can utilize will be drug like your romiflostim, L-trombopag, avatrombopag, lushutrombopag, and avatrombopag, lushutrombopag. These are all thrombopoietin receptor agonists that can be utilized. All of them are thrombopoietin receptor agonist. Thrombopoietin receptor agonist. These are thrombopoietin receptor agonists that can be having platelet stimulant property, or they are the thrombopoietin agonist. What are they? They are the thrombopoietin agonist. Interleukin 11 agonist will be 11 interleukin, नाम ही oprelvecin. ठीक है. E-poietin alpha, darmopoietin alpha, they can be utilized if there is a case of anemia. अगर anemia होगा तो ये यूज करेंगे. Filgrastim, they are the granulocyte stimulant. नाम में ये देखिए granulocyte को स्टिमुलेट करने वाले ड्रग हैं. So filgrastim as a compound they can be utilized if there is a case of leukopenia. hemo-induced leukopenia or leukopenia due to some chronic condition. Amifostine is a nephroprotective drug. It's a nephroprotective drug that is often added with the, sometime it is usually added with the cisplatin. It is usually added with the cisplatin as a compound. Next question that we are having is about a 45-year-old woman with a known case of type 2 diabetes mellitus and depression is on medication that is known as metformin, paroxetine and multivitamin. So she is taking multiple therapy now, and she has recently been diagnosed with the cellulitis and taking antibiotic for the same. Okay, so cellulitis ke liye koi na koi antibiotic she is taking. Severe, now she become agitated, delirious and severe abdominal cramp. Okay, so एंटीबायोटिक ले रही है, पहले से ही उसको देखिए पैरोक्सिटीन वगैरह जा रहा है, एंड शी इज, है ना, she has taken some antibiotic and now she is having problems like agitation, delirious, severe abdominal cramp and diarrhea. Her vitals are temperature 39, BP is on the higher side, heart rate is also on the higher side. On physical examination, she has dilated pupil, bilateral hyperreflexia, ankle clonus and started having seizure. Okay, so remember guys, which antibiotic is having this kind of problem? I have told you linezolid is having a drug that is having MAO inhibiting property, and they can increase the risk of serotonin syndrome. So all of them mostly are feature of your serotonin syndrome. So oftentimes this linezolid as a compound, they are actually going to be avoided. You are going to actually avoid them with linezolid as a drug is going to be avoided with, and linezolid as a drug is going to be avoided with other MAO inhibitor or SSRI. MAO inhibitor or SSRI के साथ इसको नहीं देते हैं. Rest other compound like doxycycline. Doxycycline is one of the tetracycline. No, it's one of the tetracycline. They can be associated with teeth staining, bone growth abnormality, है ना, or other side effect like nausea, vomiting, but they will not be causing this serotonin syndrome. Vancomycin, it's one of the drug of choice in MRSA, and they can be associated with nephrotoxicity and autotoxicity. Nephrotoxicity, autotoxicity. ठीक है. Penicillin, you already know penicillin is one of the beta lactam, है ना, they will not be having this kind of side effect. Nausea, vomiting, diarrhea समझ में आ रहा है. A 65-year-old man is a known case of hypertension, hyperlipidemia, coronary artery disease, and disease with an acute MI 2 years ago. Is complaining of muscle pain and fatigue for the past 7 weeks, and that is not related to any activity. Okay. Physical examination shows diffuse tenderness in the proximal muscle of the upper and lower limb. Which of the following drug combination can cause? So basically they are talking about myopathy. There is myopathy. He is taking multiple drugs. Dyslipidemia के लिए drug ले रहा है ना, coronary artery disease के लिए drug ले रहा है ना, acute MI भी हुआ है, hypertension के लिए भी drug ले रहा है. Now myopathy in anti-dyslipidemic drug is going to be associated with one drug called statins. And there is one more drug that is fibrates, fenofibrate, bezafibrate. These are the fibrate that we know. They are the PPAR alpha agonist. They are the PPAR alpha agonist, and statin, they are the HMG CoA reductase inhibitor. So both of them are having similar kind of side effect. That is why इन दोनों को कभी साथ में देते भी नहीं है ना. जो myopathy है, sometime it increase from simple myopathy to life-threatening rhabdomyolysis. Life-threatening rhabdomyolysis can also be seen. So correct answer for this one is atorvastatin is a statin, and gemfibrozil is one of the PPAR alpha agonists. They are the fibrate. Gemfibrozil and ezetimibe can be given because ezetimibe is inhibiting cholesterol absorption from intestine. Niacin ezetimibe again is not going to be associated with any kind of problem. Niacin can increase the uric acid level. Niacin can cause multiple problems like maculopathy. Niacin can also be associated with the increase in the glucose level, है ना. ये सारे काम करेगा, एम्ब्लायोपिया करेगा, है ना, but they will not be associated with the myopathy as a side effect. ना flushing episode भी कर सकता है ना, pruritus कर सकता है, generalized pruritus, ये सब भी कर सकता है ना. Atorvastatin ezetimibe is a drug that can be safely given. As I told you, ezetimibe is one of the NPC1L1 inhibitor. They are inhibiting the absorption of cholesterol. And so correct answer for this one is myopathy. So atorvastatin, gemfibrozil should not be given, or should be a possible cause of this one. A 30-year-old man is taking over-the-counter intranasal decongestant spray for his persistent nasal congestion and rhinorrhea. However, after a few days, he had to increase the frequency and number of sprays. So he is increasing frequency and number of sprays per nostril for adequate symptom control. On examination, his nasal terminates are pale, swollen, and clear nasal discharge. Okay. Rhinitis medicamentosa could be one of the very possible indication here, है ना? What could be possible cause? What is the likely mechanism behind the increased medication use? So again, there is the drug is not responding at the same dose, so the person has to increase the dose. And what could be the possible cause of this one? इसको हम बोलते हैं क्या? What do we call that? Development of the tolerance. Development of the tolerance. So receptor become less sensitive. Sometimes receptor is internalized, है ना? Sometimes the receptor is internalized. So increased receptor internalization could be the possible cause. Decreasing receptor affinity will not be the cause of the tolerance. Depletion of receptors with G protein reduce parasympathetic activity. Again, they are just dummy choices. Tolerance का simple सी बात हो रही है, and increasing the receptor internalization. That means receptors are hiding, they are going inside, है ना? Receptor, that is how they are not responding at the same dose. A 50-year-old woman who is on ifosfamide for the past 1 month due to her lymph node positive breast cancer presented to the emergency with frequent urination, suprapubic pain, hematuria, dysuria. See, ifosfamide के साथ अगर hematuria हो रहा है तो there is no doubt about this. This could be a case of hemorrhagic cystitis. This could be a case of hemorrhagic cystitis, and the prevention of this one we always run IV mesna. So with the drugs like your cyclophosphamide, and with the drug like your ifosfamide, this hemorrhagic cystitis is always going to be a risk, है ना? So we are going to, which of the following may have helped to avoid the current state. तो current state को avoid करने के लिए आपको IV mesna देना था. Leucovorin will be added. Leucovorin, folinic acid, है ना? They will be added with the methotrexate. Ondansetron for nausea and vomiting, किसी भी chemotherapy induced nausea and vomiting के लिए. Dexrazoxane with the doxorubicin and daunorubicin mediated cardiotoxicity. Ruby induced cardiotoxicity. इसके cardiotoxicity के prevention के लिए we will be utilizing dexrazoxane, है ना? Dexrazoxane, they are the iron chelator agent, remember. A middle-aged man suffering from chronic kidney failure diagnosed with sputum positive pulmonary tuberculosis. His creatinine clearance is 25 ml per minute on the lower side. All of the following drug require dose adjustment in renal failure except. So remember, these two drugs could be the potential answer to this one. But अगर मैं बात करूँ rifampicin की, तो that would be the correct one, because these streptomycin and ethambutol, they are mainly excreted. They are mainly excreted by the renally. ठीक है? So they require dose adjustment. They require dose adjustment in renal failure patient. Dose adjustment in CKD patients, CKD chronic kidney disease patients, they will be requiring the dose adjustment. Isoniazid rifampicin will not be, because they are mainly excreted by the hepatic route. Remember, rifampicin, it is mainly excreted, because isoniazid are having metabolism also via the non-microsomal enzyme, that is acetylation, है ना? Rifampicin metabolized in liver and excreted exclusively via biliary secretion. तो again rifampicin will be the correct, but इसमें दो आंसर हो सकते हैं, B followed by A. Next question that we are having is going to be about which antiarrhythmic drug should be given for a long-term management of the 65-year-old man patient presenting with the atrial fibrillation. Comorbidity include इसको hypertension भी है, type 2 diabetes भी है, coronary artery disease भी है, ischemic cardiomyopathy, lot of things are there, and there is 28% ejection fraction, that is also on the lesser side. So long-term usage के लिए you can utilize drug like amiodarone, that is one of the class 3 anti-arrhythmic drug. It's a potassium channel blocker, long-term anti-arrhythmic drug. अगर prolong use करना है तो इसको use करेंगे. They are also having longer T half life. Flecainide as a drug member, अगर किसी patient को cardiac comorbidity नहीं है, if there is a person, है ना, it's a class 1C anti-arrhythmic drug, है ना, utilized mainly in a patient with WPW syndrome. But इतने सारे comorbidity के साथ इसको नहीं use कर सकते हैं, long term के लिए भी again नहीं use कर सकते हैं. They are mainly sodium channel blocker. Ranolazine, they are the late sodium influx inhibitor. They are mainly utilized in angina. और इस पेशेंट के लिए अगर मैं बात करूं, वल्सर्टन तो एंटी एरिथमिक ड्रग है नहीं, ये तो वन ऑफ द ARB है, दैट इज फर्स्ट लाइन एंटी हाइपरटेंसिव ड्रग. इट्स फर्स्ट लाइन एंटी हाइपरटेंसिव ड्रग. ठीक है? सो करेक्ट आंसर फॉर दिस वन इज गोइंग टू बी योर B is the correct answer for a question like this, right? So with this we are done with our pharmacology question, and I think 13 questions were there and we have covered all of them, and the detailed description has already been given to all of you guys in booklet. We have just covered why a particular option is the correct answer and what is the reason behind that. I'll see you in my next class. Thank you very much.